And welcome back. We are moving on to chapter 11. And chapter 11 is really all about airway management. And I really want you to think of this as the most time sensitive, can't miss category on calls because when breathing is disrupted, oxygen delivery to tissues and cells is disrupted right behind it. And your cells really don't tolerate that for long. In the field, we're not just putting oxygen on people, we're making sure that the airway is open, that air can actually move in and out, and that oxygen can ultimately reach the organs that need it most, especially the brain and the heart. Because once oxygen deprivation sets in, functions drop fast and tissue damage quickly follows. Picture arriving to a patient who is, turning blue, not acting normal. That call is exactly why this chapter exists. You need a repeatable, assessment-driven approach that gets you from first look to a protected airway and supported breathing without hesitation. So as we move into the next slides, we'll anchor this chapter to the National EMS education competencies that you're really expected to master. So the first competency is basically your job description on any sick call, right? You're expected to apply your knowledge of anatomy and physiology to real-time assessment and management. So you can assure a patent airway, provide adequate ventilation, and just support respiration for patients of all ages. So here's the key mechanism to keep in mind. Oxygen reaches tissues only when air gets into the lungs. Oxygen crosses into the blood, and the circulatory system can deliver it. So if the airway is blocked or ventilation is failing, the whole chain breaks, okay, and the vital organs stop functioning normally. Clinically, that's why a patient who's cyanotic, drooling, or altered is an immediate airway and breathing problem until proven otherwise. So you don't get to just wait and see if they improve because hypoxia really doesn't negotiate, right? A common pitfall early in training is treating airway management like a set of disconnected tasks, like put oxygen on or grab a device, instead of recognizing that the purpose is physiologic: open the airway, move air effectively, and restore oxygen delivery. Next we're going to kind of zoom in on the airway specific competency pieces, anatomy, assessment, and the techniques you'll use to keep the airway open. So here, this slide gives you the airway management kind of roadmap. You need to know the anatomy, assess the airway, then use the right techniques to keep it patent, okay, or open, in that order every single time. Anatomy matters because the airway is not just an empty tube. It's a series of structures that can obstruct in real predictable ways, especially when muscle tone is lost, like an unresponsive patient where the tongue can become the most common blockage. Your assessment matters because you're deciding whether the patient can maintain their own airway and whether air is moving just cleanly, or whether you're hearing and seeing signs that something is in the way, like a noisy respiration, secretions, or poor responsiveness. Signals that really that the airway may not stay open without assistance. So here, the practical EMT application, if you skip straight to doing something without confirming what's actually happening at the airway level, you could actually worsen the situation. For example, forcing an approach that triggers vomiting or pushes material deeper instead of clearing the path for air. So think of the clinical anchor from this chapter's scenario. A patient who is drooling and cyanotic isn't just short of breath, right? That presentation should push you to immediately prioritize airway patency and readiness to clear secretions while preparing to support breathing. So next we're going to expand just beyond the airway itself and distinguish the kind of broader breathing processes, ventilation, oxygenation, respiration, so your assessment can match the real life physiology. So on calls, the word breathing, the use of the word breathing to mean everything, but as an EMT, you have to separate the process on this slide because they fail in different ways, and your treatment priorities depend on which link is actually breaking. Pulmonary ventilation is like simply moving air into and out of the lungs, where oxygenation is loading oxygen onto the hemoglobin in the bloodstream, and respiration is the actual exchange of oxygen and carbon dioxide externally at the alveoli and internally at the tissues. So cells can keep producing energy and clearing waste. So mechanicalistically, this all kind of depends on diffusion and on the circulatory system carrying oxygenated blood where it needs to go, which is why a patient can sometimes look like they're breathing but still failing at oxygen delivery if the process is disrupted beyond just simple airflow. A useful like field anchor is the classic, turning blue presentation. You don't just ask, are they breathing? You ask, is air moving? Is oxygen getting into the blood? And is the body actually benefiting? So, because those answers drive whether you focus on airway opening, ventilation support, oxygen therapy, or just rapid transport for an underlying pathology. One common pitfall is assuming that any single measurement or observation proves the whole chain is working, like treating the presence of chest movement as proof of effective breathing, when you still need to consider whether ventilation and gas exchange are actually adequate. So next, we're going to really just apply these definitions to what you can assess at the patient's bedside, how to recognize adequate versus inadequate ventilation, and how to supplement oxygen, how supplemental oxygen fits into that plan. So the other EMS education standard, this really just turns definitions into what you actually do on scene. So you assess whether ventilation is adequate or inadequate, and that decision really determines whether the patient just needs support light oxygen therapy or whether they just need you to actively assist their breathing because their minute to minute oxygen delivery is in danger, right? So pattern recognition is huge here. Adequate breathing generally looks like a normal adult rate with like regular chest rise and fall, clear and equal lung sounds, and enough depth to move real air. While inadequate breathing shows us at rates that are too slow, too fast, with shortness of breath, shallow depth, irregular patterns, diminished or noisy sounds of some sort, and just visible increased work like accessory muscle use or retractions, because those findings tell you that the patient is failing to move effective air. The EMT implication here is simple, but again, it's super critical. Oxygen is not a substitute for ventilation. If the patient can't move air effectively, passive oxygen delivery has really limited value. And you have to be ready to support ventilation while protecting the airway. Again, another common pitfall is just waiting for the late signs like cyanosis before acting or relying on a single tool to tell you that the patient is okay. Instead, you treat based on the whole clinical picture: mental status, skin signs, work of breathing, and what you hear and what you see. Then reassess frequently to confirm your intervention is actually improving the patient. Okay. So next, we're going to actually shift into the next competency of artificial ventilation. Connect how your interventions can support breathing while also affecting circulation if we overdo them. And again, this is just a broad strokes talking about the different educational competencies that all EMT programs must adhere to. So so here, this competency block tells you what you're expected to be able to do when ventilation is the kind of limiting problem. Recognize when breathing is adequate versus inadequate, and then support it in a way that actually improves gas exchange. So when we talk about minute ventilation, think of it as a simple product of respiratory rate and tidal volume. So a patient can have a rate that looks okay but still have inadequate overall ventilations if breaths are shallow. Alveolar ventilation takes that one step further by focusing on the air that actually reaches the alveoli, because air stuck in that dead space doesn't really participate in gas exchange. This is why fast, shallow breathing can look busy but still be ineffective. Clinically, really picture a patient who's breathing but only getting out a few words at a time, looks fatigued. That pattern should push you to consider whether they're maintaining enough effective ventilation and not just whether the chest is actually moving. Another common issue is treating ventilation like more is better, especially once you start assisting. This chapter really emphasized that positive pressure ventilation can change intrathoracic pressures and reduce venous return. So we'll be deliberate later about using appropriate rate and just really enough volume to see chest rise. Next, we're going to broaden the lens to the underlying pathophys. So your ventilation decisions are really tied to what's happening in the lungs and circulation. So, again, this competency is just a reminder that airway and breathing problems are not just mechanical. They're physiologic problems you interpret at the bedside, and your assessment needs to consider both respiration and perfusion. So, from a practical standpoint, patients can look like they're actually breathing and still be in trouble if ventilation and perfusions aren't matched, okay, well enough at least for actual gas exchange to take place. So this chapter is going to highlight ventilation and perfusion mismatch as a common reason oxygen and carbon dioxide exchange fails. And it's really a useful mental model when oxygenation doesn't improve the way you would actually expect. Now, for an EMT, the implication isn't that you diagnose a specific disease on scene, it's that you recognize patterns that suggest the system overall is failing. Your altered mental status, poor skin signs, and just persistent distress by the patient. And then you treat the immediate life threats while planning transport and reassessment. Okay. A common issue here is just like is really anchoring on a single explanation, like assuming every shortness of breath call is purely airway or purely lungs, instead of using really a broad differential that includes perfusion problems, environmental factors, mechanical limitations to ventilations. So you got to look at the patient holistically, okay? So now we're going to actually switch to the actual intro of this chapter and kind of just start the deep dive. All right, so here it's all about setting priorities. All right, in the early phase of any call, confirming that a patient can breathe adequately is foundational because oxygen delivery depends on two connected systems, right? Moving air into the lungs and circulating oxygenated blood to tissues. Mechanically speaking, this chapter really describes oxygen moving from the atmosphere into the lungs, crossing the alveolar membrane, and binding to the hemoglobin. Okay, and then being carried through the body while carbon dioxide is returned to the lungs and then exhaled. Right. So if breathing is disrupted, that whole exchange and delivery pathways really start to fail. Okay, so clinically, that's why patients in respiratory distress, they often show early changes that you can detect without advanced tools. Restlessness, anxiety, increased effort, before you see later findings like cyanosis, mental status decline. Your job is to notice the trends and then intervene based on the assessment. A useful field anchor here is that the classic dispatch report that someone is turning blue and not acting normally, you can't determine the exact cause from just the dispatch notes alone. But you can really treat it as an airway ventilation or oxygenation problem until your assessment actually narrows it down. And again, a common issue is that to equate, breathing with oxygen delivery, when a patient may still have respiratory effort but poor effectiveness. So that's kind of the issue. So here, the next slides, we're going to start really building on the anatomy, kind of a review of chapter 6. That way you can really localize where the problem is actually occurring. So this figure, again, you should have seen this before. This figure is here to really give you a visual map before we start naming structures. It shows just how the airway is organized into an upper, lower portion and is placed those structures in relation to the lungs and the breathing muscles that move the chest. Okay. So as you look at it, really the teaching point is that ventilation is not just air in the mouth. Air has to travel through a continuous pathway to reach the alveoli. And the diaphragm and the intercostal muscles create that chest movement that allow that air movement to actually happen. Clinically, this helps with pattern recognition. When you see increased work of breathing, what you're often seeing is the body like recruiting different muscles to actually move air through that pathway more effectively. Okay, which can be a clue that resistance is increasing somewhere along that route. Okay. A common pitfall here is to focus only on the mouth and nose during assessment, and then you forget that the lower airway structures and the lungs themselves can be the limiting factor. So the map on the slide is just a reminder to assess the whole system, air movement, breath sounds, chest rise, and then decide where the problem likely is. So next we're going to actually put this words into the picture and define the respiratory system and how it divides into just upper and lower airways. So the respiratory system, right? So let's try to look at it in a practical way. It's the set of structures that form the airway and just allow us to ventilate, meaning move air into and out of the lungs. And the airway is organized into upper and lower sections. That division matters because it helps you localize the problems during your assessment. Upper airway issues often involve obstruction, swelling, secretion, loss of tone, while the lower airway and lung problems more often affect how air is delivered to the alveoli and how well gas exchange can occur once it gets there. The textbook really ties this directly to what you see clinically. Chest rise and fall reflects the mechanics of ventilation, and breath sounds help you decide whether air is moving effectively through that pathway. Um, so moving on, here we're going to kind of orient you to the upper airway itself. As an EMT, you want to recognize these structures because most early airway threats you kind of manage are going to live right here, right? Things like loss of tone, and when I say tone, is muscle tone, secretions, foreign material that kind of block airflow before it even has a chance to reach the lungs. The nose and mouth are the kind of like the main entry points, and the practical difference is in the field at least is that nasal obstruction, mouth breathing, or facial injuries can change how well a patient moves air and how easily you can actually manage that airway. The oral cavity is especially important because that's where the tongue, vomitus, blood, dentures, or just other kind of materials can quickly compromise patency. So your initial airway check is not just, hey, are they breathing, but is there anything in the way and can air actually pass? The pharynx here is the shared passageway behind the nose and the mouth, which is why airway protection is like one of the most important things to do. If materials like of any sort kind of pool there, it can really migrate towards the laryngeal opening, especially in patients with altered mental status. A common issue here of newer EMTs is the thinking of airway as only the mouth opening. Instead, train yourself to like scan these structures as a system and anticipate which one is most likely causing obstruction based on what you see and just what you hear. Now, the upper airway itself isn't just a tunnel for airflow. It really conditions the air by warming, filtering, humidifying as it enters, which kind of helps protect the lower airways from irritation, contaminants, and just supports the more effective breathing overall. The pharynx or the throat is a kind of muscular tube that links the nose and mouth to the point where the body has to choose a path, okay? Because at its lower portion, the airway route continues towards the larynx and trachea, while the digestive route continues towards the esophagus, right? So that's why the pharynx is really such a high yield place, if you will, to think about airway risk. If a patient who is, drooling, vomiting, decreased level of consciousness, that material can actually collect here and threaten the airway if the patient's protective reflexes are impaired in any way. The chapter does a good job breaking down the pharynx into kind of three different regions: the nasopharynx, oropharynx, and the laryngopharynx. And you'll use that framework kind of later when you decide what you're seeing and what interventions make sense. Whether that's just simply positioning, clearing secretions, or choosing an adjunct of some sort. Um, Another issue newer EMTs use or fall into rather is to treat all throat problems the same. Instead, Use these subdivisions and keep your assessment organized and to anticipate where airflow secretions are more likely to be compromised. So now the nasopharynx is the upper portion of the pharynx that inspired air typically passes through when a patient is breathing in through the nose, and its main job is simply to condition the air before it goes deeper. Functionally speaking, it filters dust and small particles that help warm and humidify incoming air. And the mechanism that the chapter really emphasizes is that it's lined with a mucous membrane and cilia that trap contaminants and really reduces what reaches the lower airway. Clinically speaking, this becomes relevant when patients can't effectively breathe through the nose because of congestion, facial trauma, or an obstruction. Since they lose that normal conditioning pathway and may switch to mouth breathing, which can really change comfort and secretion management. So the figure on this slide really supports the spatial understanding by showing the pharynx and helping you see where the nasopharynx sits relative to the rest of the throat, which matters when you're thinking about airflow routes and where the secretions might be pooling. Um, and then a common issue here is assuming that nasal breathing is always happening. So in real calls, you should quickly notice whether the patient is mouth breathing or has some type of nasal obstruction, because that can change what you see and what you hear, and really how you position and manage the airway. Now, with the oropharynx is the more posterior portion of the oral cavity, and for EMTs, it's a high kind of yield region because it's where airway patency can be lost relatively quickly, especially when the tongue relaxes or when secretion, blood, or vomitus accumulate behind the mouth. The anatomy really frames kind of and helps you visualize that this is the space behind the mouth where the airway and digestive pathways are still in close proximity, which is why airway protection becomes a core concern in patients with altered mental status. The epiglottis, sitting kind of superior to the larynx, is one of the body's key protective structures, where during swallowing, the larynx elevates and the epiglottis folds over the glottic opening to reduce aspiration into the trachea. But if protective reflexes are impaired, that protection is really less reliable, and airway contamination kind of becomes more likely. A clinical like kind of anchor for you is the patient who is drooling or has fluid draining from the mouth. Your assessment should really immediately consider whether that material is kind of threatening the oropharynx and whether you need to prioritize clearing and maintaining the airway, really just before focusing on just other interventions. This figure right here is kind of meant to make the oral cavity kind of feel solidified, because this is a space you're visually assessing and working in when you open the airway, right? Clear obstructions and suction or place, a BLS airway adjunct, which we're going to cover later on in the chapter. The oral cavity is bounded by the palate above, the cheeks laterally, and the tongue below, and the anatomy explains a lot of what you see clinically. The tongue itself can really dominate that space, and when tone is lost, where it shifts posteriorly and narrows the passage towards the pharynx, while the fluids and the loose materials can sit along the tongue and cheeks where they're easy to miss without a deliberate scan. The real EMT implication is that your airway check needs to be systematic. Look for visible obstructions, pooled secretions, dentures, foreign material, and then choose interventions that clearly can clear and maintain patency without making things just worse. Um, this slide introduces the larynx, which you can think of as a transition point where the upper airway ends and the lower airway begins. And that matters because many airway threats you manage are about keeping airflow moving smoothly through the gateway, so to speak. The chapter really describes the larynx as a kind of complex set of cartilaginous structures, and functionally, that complexity supports two practical outcomes. It helps with speech production, and it protects the lower airway from just unwanted material when the reflexes are kind of working normally. In Figure 11-6 here, you're really looking at the larynx as a structured framework rather than just kind of a vague kind of throat space, if you will, which is kind of helpful when you're trying to visualize why swelling, fluid, or irritation in the region can narrow airflow quickly compared with, the wider parts of the airway. Clinically speaking, anchor this thought, is the patient with secretions or vomitus that's threatening the airway, right? Your immediate EMT focus is to maintain patency and reduce aspiration risk, because material contacting that laryngeal airway can trigger protective closure and make ventilations just more difficult. So here we're just labeling the three laryngeal landmarks you'll hear repeatedly in airway management. You have the thyroid cartilage. That's the more prominent anterior structure that kind of forms the V shape, which the text really describes as a shield-shaped cartilage that creates a kind of laryngeal prominence. So it's a useful like kind of orientation point when you're thinking about the front of the neck anatomy. We have the cricoid cartilage, sits just sit just inferiorly, below it, and it's the what's called the first ring of the trachea. The chapter adds really an important functional detail that it forms a complete ring, which helps you understand why this junction is just a clear dividing line between the larynx and the trachea. Then you have the glottis. The glottis is the opening between the vocal cords, and it's really emphasized uh, where two clinically useful points. It's the narrowest portion of the adult airway, and the vocal cords have kind of protective reflexes that can close to prevent substances like water or vomitus from entering the trachea. A clinical anchor here is that the patient with fluid and a decreased level of consciousness, your job is simply to anticipate that material near that glottic area can worsen airflow by triggering in that protective closure. So airway clearance and reassessment becomes like the most urgent prioritization. So now let's actually talk about the lower airway, right? So the lower airway, its job is to deliver oxygen to the alveoli, okay? Because that's where oxygen and carbon dioxide exchange is going to occur. So the entire lower airway is essentially a delivery route to gas exchange, the surface of the gas exchange. The lower airway includes the trachea, which serves as like kind of the main conduit, the bronchi, which splits airflow into right and left lungs, and the lungs, which contain the smaller passages that really ultimately lead to the alveoli. Clinically speaking, this helps you keep your assessment just organized. If you've opened the upper airway and it appears clear, but the patient still has poor air movement or poor response to just basic interventions, you should be thinking about whether the problem is in this lower pathway or at the level of the lungs where the exchange actually takes place. A simple field anchor, if you will, is the patient who is working to breathe, right? Your assessment isn't only is the mouth clear, but is air getting to where it needs to go, which you infer really from the chest rise, the breath sounds, and overall ventilation effectiveness. Okay. As I mentioned, the trachea is really the primary conduit for air entry into the lungs. And your textbook really adds helpful detail that it's a tubular structure supported by cartilaginous rings, which is one reason it tends to remain open as air moves towards the chest. As it travels into the thoracic cavity, it divides at the carina into the right and left main stem bronchi, and those bronchi are supported by cartilage, and they distribute the air into each lung. So structurally speaking, this is the point where one airway becomes two lung pathways. From a clinical standpoint, this branching concept kind of supports a key assessment habit that you already use, right? Listening and comparing breath sounds side to side because effective ventilation depends on air reaching both lungs through these main branches. A practical anchor is a respiratory distress patient where you're reassessing after an intervention. Knowing the trachea divides into two bronchi reinforce why you're checking for equal air movement rather than just assuming that chest movement alone tells the whole story. Now, a common pitfall for this one is forgetting that airflow distribution can be uneven even when the upper airway is clear. So you continue to verify ventilation effectiveness with objective findings like bilateral breath sounds and just equal chest rise and fall. Here we have what's this figure 11-7 is where it helps to see the lower airway as a kind of a connected pathway rather than just separate vocabulary words, right? The trachea descends into the chest and serves as really the central tube for delivering air, and the lungs represent the destination structures where that airflow is distributed and ultimately brought to the alveoli for gas exchange. So even without adding new labels on this, slide, the key teaching point is just spatial. When you're assessing breathing, you're trying to determine whether air is traveling through the entire route effectively and reaching both lungs. Because ventilation problems aren't solved just by, placing oxygen near the face if the pathway isn't open or, airflow isn't reaching the lungs, at least effectively. A clinical anchor is a reassessment during a respiratory call. Okay, so after you reposition a patient or support ventilation, this figure is just a reminder of what you're trying to accomplish. Consistent airflow down the trachea into both lungs, while finding that match with findings that really just match a goal. Okay. So now we've kind of followed air down the trachea and into the main bronchi, and this slide really takes you one step deeper into the lungs. The bronchi keep dividing into smaller airways called bronchioles, and a key feature is that bronchioles are made of smooth muscle, okay, meaning their diameter can change in response to different stimuli, which directly changes how easily air moves through them, okay? So those smaller bronchioles will lead into the alveoli, and the alveoli are the thin-walled sacs where oxygen and carbon dioxide exchange is going to occur. So the bronchioles are essentially the final delivery tubes that bring fresh air to the gas exchange surface. Now, mechanically speaking, once oxygen reaches the alveoli, it diffuses across the alveolar membrane into nearby pulmonary capillaries and binds to the hemoglobin. And that oxygenated blood then returns to the heart to be pumped out to the rest of the body. So, really, effective ventilation is only valuable if that air is actually reaching these distal structures. A clinical kind of anchor is that patient who seems to be breathing fast but is still not improving. This slide really helps you remember that speed alone doesn't guarantee an effective airflow to the alveoli if the small airways are narrowed or if the breaths are too shallow to move air beyond that dead space. Um, so here we can actually see that the chest is kind of a shared workspace, if you will. The thoracic cavity contains the lungs and airway structures, and you're trying to ventilate, and it also contains the heart, those great vessels, and must deliver oxygenated blood to the tissues, which is why breathing and circulation are really inseparable in real patient outcomes. Here in 11-8, notice the proximity of the trachea, and the bronchi to the heart, the aorta, the vena cava, with the diaphragm forming kind of the floor of that thoracic cavity. So this layout is the foundation for really understanding why problems in the chest can affect both ventilation and perfusion. Okay, and then here on figure 11-9. This kind of uses the bell jar model to make the mechanics of inhalation kind of simple. When the diaphragm contracts and moves downward, the thoracic cavity just kind of enlarges, pressure inside drops, and air is actually pulled into the lung, right? So this negative pressure ventilation, okay, and is driven by chest wall and diaphragm movement, not by the lungs actually doing any work themselves, okay? So if you're thinking about like as an EMT, when you're assessing a patient with labored breathing or just having more work of breathing, shortness of breath, difficulty breathing, when you see visible effort, you're often watching the body recruit muscles to really expand that thorax and maintain airflow, which should cue you to evaluate ventilation effectiveness and fatigue risk rather than just counting the patient's breathing rate. Um, the mediastinum, okay, so is really the central space in the thorax between the lungs, and this slide kind of lists what lives there. So you have the structures that matter in airway management because they're the major, pipes and pumps supporting ventilation and circulation. It contains the heart and great vessels, which is really responsible for moving oxygenated blood to the tissues. It also contains the trachea, the major bronchi, which are the, again, the main conduits to allow airflow to the lungs. And then we have the esophagus, which sits in close relations to these airway pathways and reinforces the concept that air and food share really a tight, like, real estate in the upper chest. The slide also notes that many nerves and a practical way to interpret that is to remember that, the nervous system control is part of breathing. Signals to breathing muscles are required for effective ventilation. So disruptions in this region can have downstream effects you detect as inadequate ventilations. If we look at, clinically speaking, if we look at our reassessment, a patient after airway positioning or ventilation support, the goal is to not just get air in, right? But to ensure the integrated, chest system that we're talking about is functioning well enough that ventilation can be maintained without worsening the patient's overall status. So now we can look at the big picture, right? The physiology of breathing. Okay, the respiratory system and the cardiovascular system function as a paired system, so cells receive a pretty much a steady supply of oxygen and nutrients, and so carbon dioxide and other waste products can be removed more efficiently. Mechanically wise, air must be ventilated into the lungs. Oxygen must cross into the bloodstream and bind to the hemoglobin, and the heart must pump that oxygenated blood to the tissues. Now, at the same time, carbon dioxide produced at the cellular level is carried back to the lungs and then exhaled, completing the loop. Okay. The EMT implication here is that your initial assessment has to make room for both sides of the equation, air movement and circulation, because improving one while ignoring the other may not improve the patient's overall condition, at least not the way you would expect it to. So if we think about this as a patient who is having difficulty breathing or just shortness of breath, right? Um, and you're kind of comparing two different patients, right? One may be struggling to move air, right? And that's going to be more of a ventilation problem, while another may be breathing adequately but still look pale, altered. And that is because circulation is compromised. And the same work of breathing complaint can represent different failures in that partnership. So here we have table 11-1. So this table is here really to keep your terminology, okay, and therefore kind of decision making more clean, if you will. Ventilation is again that physical act of moving air into and out of the lungs. Oxygenation is loading oxygen onto hemoglobin in the bloodstream, and then respiration is the exchange of oxygen and carbon dioxide in the alveoli and in the tissues. So we defined these earlier, but the added value of just kind of seeing them side by side is that it gives you a quick way to sort what you're kind of observing. If air isn't moving effectively, you're really dealing with a ventilation problem. If air is moving but the patient still isn't benefiting, you start thinking about whether, hey, is oxygen being loaded and delivered appropriately? And if gas exchange or tissue delivery is failing, right? The patient may look worse despite what appears to be, appropriate breathing. Ventilation. So ventilation is like we just talked about, is the physical movement of air into and out of the lungs. And it's really the first half of that cycle is inhalation. Okay, is an active process that really requires muscles to work. During inhalation, that diaphragm and the intercostal muscles will contract. The thoracic cavity enlarges, pressure inside that chest drops below the atmospheric pressure, and air is going to be drawn in to equalize the pressure difference. That's the core idea behind that negative pressure ventilation. Now, in the field, that mechanism kind of matters because anything that limits chest expansion can really limit ventilation even when the air opening looks fine. So you're not just looking for breaths, you're watching for effective chest rise and the effort required to produce it. Um, Clinically speaking, if we look at this, we can kind of see a patient who has like significant chest wall injury, who's trying to breathe but can't generate good expansion, right? Understanding that inhalation depends on chest movement kind of helps you recognize why their ventilation may be inadequate even before you get to like more advanced assessments. So, because the lungs don't have muscle tissues to expand on their own, effective ventilation depends really on the movement of chest and the supporting structures that change thoracic volume. Okay, which is why restrictions on chest movement show up quickly as just reduced ventilations. Now let's talk about the next really key concept is partial pressure. Okay, so it's a simple way of kind of describing how much of a gas is present in a mixture, like air, or dissolved in a fluid like blood. And it matters because gases move based on gradients, not on necessarily intention, right? Diffusion is the mechanism the chapter kind of really emphasizes. Oxygen and carbon dioxide move from areas of higher concentration or pressure to lower concentration or pressure until things equalize. And that's really the principle is what makes gas exchange possible in the lungs and the tissues. Um, a clinical example here is that a patient with shallow, restricted chest movement, right? Maybe they're fatigued, splinting or constrained in position, because even if their rate looks elevated, poor expansion means less fresh air reaches the exchange surface, and diffusion can't do its job without ventilation delivering gas where it's needed. So once again, the bell jar model is a useful way to kind of visualize exhalation. Okay, so when the diaphragm and the intercostal muscles just relax, the thoracic cavity can return towards its kind of resting size. The pressure inside the chest rises relative to the atmosphere, and the air is pushed out through the trachea until just the pressures equalize again. So the image here reinforces that exhalation is just typically passive under normal conditions, more about recoil and relaxation than active muscle effort. So, a patient's ability to exhale effectively really depends on an open pathway and enough time for that air to actually leave the lungs. A practical real world scenario is, you're reassessing a patient you're assisting with ventilation, right? So you're not only watching for chest rise, you're also watching for full chest recoil between breaths because any incomplete exhalation changes the pressure dynamics and can really interfere with ventilation effectiveness overall. Now, inspiration, again, is ultimately, again, all about delivering oxygen to the alveoli. But the chapter kind of makes a key point. So, not every breath delivers its full volume to gas exchange surface, right? So, tidal volume is the amount of air moved in or out with each breath. And dead space is that portion that inspired air that doesn't really reach the alveoli, and therefore it really doesn't participate in that gas exchange process. That distinction kind of gives you a practical assessment kind of lens. A patient can have a fast respiratory rate and still have poor effective ventilations if the breaths are shallow, because more of each breath is spent in that dead space rather than reaching down to the alveoli. So think about if the think about your patient who is breathing rapidly but with minimal chest rise, right? If they're panting and can't speak in full sentences, you should be thinking about whether that their tidal volume is adequate enough to overcome that dead space and then maintain that effective ventilation. not just whether the rate is high. A common issue or misconception is, the documenting only rate and just missing the depth, right? Avoiding it means deliberately assessing chest expansion quality and recognizing that improving effectiveness may require supporting ventilation rather than simply applying oxygen. Exhalation usually doesn't require, again, any active muscle effort because it's just driven by the relaxation of the diaphragm, the intercostal muscles, and it's really just the natural recoil of the chest. So as thoracic volume decreases, the pressure inside the chest will increase, and the air is pushed out through that airway. That simple, really mechanical idea has a practical EMT takeaway, right? Air will only move in and out if the airway remains patent. So maintaining an open airway, more specific, an open pathway, is just as important for exhaling, as it is for inhaling. So when assessing for breathing, it helps to know what's really driving that rate and depth that you're seeing, right? Because the body is constantly adjusting ventilation through receptors, feedback loops, just to match the oxygen demands and the removal of the carbon dioxide. I know that the textbook does a good job emphasizing that for most people, the primary drive to breathe is tied to pH changes related to carbon dioxide levels. Because as carbon dioxide levels rise, the pH will fall and it signals to the respiratory center to increase the urge to breathe. So a change in ventilation pattern often reflects the body's trying to correct a chemistry problem, not just being anxious. So if the system can't keep up, that's when hypoxia develops. And clinically, that can show up first as like restlessness, irritability, anxiety, before the later findings like, mental status changes, weak pulses, cyanosis. So that's why you don't wait for those late signs to decide, hey, a patient is in trouble. In some patients with end stage COPD, the chapter describes the theory of a secondary hypoxic drive where the body may rely more on low oxygen levels to stimulate breathing. The practical EMT takeaway there is that you still treat the patient in front of you and give oxygen when it's needed. High oxygen should not be withheld from a patient who is severely compromised. A common issue and pitfall is letting the phrase like hypoxic drive turn into hesitation. Instead, use it just as a reminder to reassess frequently and titrate care to the patient's clinical status while prioritizing correction of hypoxia. Now, oxygenation is, again, specifically the step where oxygen molecules are loaded onto hemoglobin in the bloodstream. And that's really why it's central to everything downstream. If oxygen isn't on hemoglobin, it can't be transported effectively to the tissues for internal respiration. This chapter also makes an important distinction. Oxygenation is required for internal respiration, but it doesn't automatically guarantee internal respiration is happening, right? Because the body still needs adequate delivery to tissues and effective exchange at that cellular level. Okay, so now one reason this matters to EMTs at least is that ventilation can occur without effective oxygenation. When the air is being ventilated, it doesn't contain enough usable oxygen, such as in confined spaces where oxygen is depleted, or in environments where there's toxic gases that displace oxygen. In those specific situations, you may see respiratory effort, but the patient is still not oxygenating adequately. Okay. A practical kind of field example is arriving to multiple people with similar symptoms in a poorly ventilated environment. Before you focus on just the patient, you consider the air quality and the scene safety because the problem may be in the environment itself. A common issue is assuming that visible breathing, again, automatically means oxygenation is adequate. Instead, you really need to pair what you see with the patient's overall clinical picture and the environment, and then treat based on the likelihood of impaired oxygen delivery. So, Respiration is that actual exchange of oxygen and carbon dioxide for not only in the alveoli, but also in the tissues. And the reason that exchange matters is just the metabolism, right? Cells extract energy from nutrients through cellular process that really requires a steady supply of oxygen and produce carbon dioxide as a waste product. In the presence of oxygen, cells can produce energy pretty efficiently through aerobic metabolism. When oxygen delivery is inadequate, cells shift towards anaerobic metabolism, which can't meet normal energy demands and leads to the accumulation of metabolic byproducts. So the patient's overall condition can deteriorate even if you still see some breathing effort. Um, a clinical presentation of this one is a patient who is breathing but becomes increasingly confused or fatigued. That should really cue you to think beyond just the rate and consider whether the oxygen delivery and carbon dioxide removal are keeping pace with, the cellular needs. A common misconception for new EMTs is just using the respiration as a synonym for breathing. Okay. So instead, keep the distinction clear. Breathing moves air, but respiration is the exchange that really makes energy production possible and waste removal effective. Now, external respiration, or just pulmonary respiration, is the exchange that happens at the level of the alveoli, where fresh air is brought into close contact with blood in the pulmonary capillaries, so oxygen can move into the bloodstream and carbon dioxide can move out to be exhaled. The key mechanism is just diffusion across the alveolar membrane, and the figure here is really reinforcing that distinctionality, if you will. Oxygen moves from the alveolar air into the capillary blood, while carbon dioxide moves from blood into the alveoli, and it's all driven by that concentration gradients. For an EMT, at that level of thinking, the practical takeaway is that ventilation, again, is necessary to deliver fresh air to the alveoli. But the chapter is clear that, ventilation alone doesn't guarantee external respiration is effective. Okay. So you still assess whether the patient appears to be benefiting, not just whether the chest is moving. Okay. So for example, when you're reassessing after an airway maneuver or assisting ventilation, right? You're looking for signs that gas exchange is improving, like more stable mentation and reduced work of breathing, rather than relying on one just observation in isolation. Now, moving on, internal respiration, right? So, internal respiration is the exchange that happens out in the tissues, okay? Oxygen leaves the systemic capillaries to enter cells, and carbon dioxide produced by, again, metabolism leaves the cells to enter the bloodstream and return to the lungs for elimination. The figure here is really emphasizing that this isn't a lung-only process, okay? Oxygen delivery only matters if it actually reaches the tissues at the tissue level. And that depends on both oxygen being carried on the hemoglobin and on adequate perfusion to move blood to the actual capillary beds where the diffusion actually occurs. Um, if you think about like a patient who like just remains pale, altered, uh, poorly perfused despite apparent breathing effort, that pattern should push you to consider whether tissue delivery is the limiting step and to keep your assessment kind of broad while you manage airway and ventilatory support. A useful way to interpret abnormal breathing patterns is to remember that ventilation is regulated by the nervous system, and chemoreceptors are essentially the body's sensors for whether gas exchange and acid-base balance are staying on track, right? These receptors really monitor oxygen and carbon dioxide levels, hydrogen ion concentration, and just the pH of the cerebral spinal fluid. Then feed that information back to the respiratory centers so that the brain can adjust the rate and the depth of breathing to match the demand. Mechanically speaking, rising carbon dioxide, falling pH stimulate increased ventilation to remove that CO2. So when you see a patient, speeding up their breathing, it may be a physiologic attempt to correct a chemical problem rather than a simple, anxiety response. Um, so if you think about if a patient with altered level of consciousness after taking like a sedating substance of some sort, if the nervous system is depressed, that drive to breathe can actually drop, and you may see slow, shallow respirations relatively quickly, and just become inadequate even before other vital signs fully, show themselves. So once you've separated ventilation, oxygenation, and respiration, like conceptually, VQ matching explains why some patients seem to be breathing but still don't, oxygenate well. Ventilation again is the airflow to the alveoli. Perfusion is blood flow to the pulmonary capillaries, and effective gas exchange requires those two to arrive at the same place at the same time. So diffusion can actually occur across that alveolar membrane. When ventilation and perfusion don't match, the oxygen and carbon dioxide exchange just becomes inefficient. And the chapter really emphasized that this mismatch sits behind a large portion of oxygen and CO2 exchange like problems. So if you think about like a patient whose oxygen sats don't improve as expected with supplemental oxygen and a basic airway support, you don't jump to assuming that oxygen isn't working. You consider whether the underlying issue is that the lungs and the circulation aren't pairing the air with blood effectively. So now, when ventilation and perfusion are mismatched, the practical outcome is kind of straightforward. Some blood passes through the lungs just without being properly oxygenated, and the carbon dioxide may not actually be eliminated effectively. So true gas exchange is going to be impaired. If ventilation compromised, if ventilation is compromised but perfusion continues, blood moves past alveoli without adequate oxygen diffusion into the bloodstream, and carbon dioxide removal is also reduced, leading to worsening hypoxemia and carbon dioxide retention. So, if perfusion is compromised in a ventilated area, um, oxygen is present in the alveoli, but there isn't enough blood flow to pick it up. So, the patient still ends up hypoxemic. So a clinical representation of this is a patient who remains cyanotic or altered with ongoing respiratory distress despite good effort or oxygen delivery. This pattern really fits with exchange isn't happening, right? So rather than air isn't moving, and it should drive frequent reassessment and prompt transport planning while you continue your supportive care. So when ventilation is failing, right? Sorting causes into intrinsic versus extrinsic, helping you kind of move from observation to action without guessing. Intrinsic factors include, infections or allergic reactions, which can narrow the airway through swelling and unresponsiveness, where loss of muscle tone makes the tongue really the most common obstruction. So your first line EMT priorities often become airway positioning, clearing secretions, and maintaining patency with basic maneuvers and adjuncts, as indicated. Extrinsic factors include, trauma, and the chapter really emphasized that injuries to the airway kind of quickly, well, not just the airway, but to the face, to the chest, can really disrupt airflow just quickly. So you evaluate for mechanical limitations to ventilation and anticipate that airway management may need to be more like hands-on while maintaining appropriate precautions, especially when trauma is suspected. Um, a clinical example, is when you're arriving to an unresponsive patient with, snoring or gurgling respirations. That pattern fits loss of tone plus secretions, and it's a ventilation problem until you correct the obstruction and reassess airway movement. A common pitfall is to focus on one category and just miss the other, treating every breathing problem as lungs while overlooking a simple upper airway obstruction, or treating every airway problem as a tongue issue while missing chest trauma that's limiting ventilation. So the fix is to deliberately scan for both intrinsic and extrinsic contributors during your primary assessment. So now respirations can fail even when the airway is open and air is moving, right? And the chapter organizes the causes into external and internal factors to help you interpret what you're seeing. Externally, atmospheric pressure and the partial pressures of oxygen matter because oxygenation really depends not just on breathing something, but on having enough usable oxygen available to load onto hemoglobin. At high altitudes or in oxygen depleted enclosed spaces, ventilation may continue while oxygenation becomes inadequate. Internally, conditions like pneumonia, pulmonary edema, COPD, emphysema, they reduce effective gas exchange either by decreasing the functional surface area of the alveoli, filling alveoli with fluid, or just limiting airflow through narrowed passages. So oxygen and carbon dioxide exchange becomes inefficient even if the patient is working hard to breathe. An example is, the patient who is persistently hypoxemic and is still laboring despite oxygen therapy. That pattern should really push you to consider that the limiting step may be gas exchange rather than simply airway patency, and to reassess frequently while just again planning your supportive care and transport. Now, circulatory compromise is the just a reminder that oxygen delivery doesn't end at the lungs. Cells only benefit when oxygenated blood actually reaches them. So trauma that interferes with blood flow can create a really serious oxygen delivery problem, even if you've managed the airway and ventilation appropriately. Chest injuries like a pneumothorax, whether it's a simple tension, open, and blood in the chest, like a hemothorax or a hemopneumothorax, can obstruct or limit effective blood flow and ventilation mechanics, which really disrupts the body's ability to just match airflow with perfusion and deliver oxygen to the tissues. So if you just picture a trauma patient who is, short of breath with worsening skin signs, declining mental status, despite your airway positioning and oxygen support, that pattern should really cue you to think perfusion in the chest is compromised rather than just assuming that the issue is purely airway obstruction. Okay. A common issue is getting just so locked into an airway only mindset and missing the chest as the driver of the actual problem. The correction really is to integrate lung assessment with perfusion clues like skin condition, pulse quality, and just the overall trajectory of the patient. So you can prioritize rapid transport and continued reassessment while supporting ventilation and oxygenation. Now, beyond chest trauma, circulatory compromise can come from just a system-wide problem that really reduces either the amount of circulating blood or the blood's ability to carry oxygen. And the slide lists the major patterns to recognize. Blood loss and hypovolemic shock reduce circulating volume. So even if the lungs are oxygenating normally, less oxygenated blood reaches capillary beds and tissues begin to really shift towards that anaerobic metabolism. Anemia is kind of different. Volume may be present, but there are fewer red blood cells and less hemoglobin available to carry that oxygen. So the transport side of oxygen delivery is limited. We have vasodilatory shock, which is another kind of mechanism where blood volume isn't the only variable. When vessels dilate, pressures can drop, and perfusion becomes inadequate. Again, limiting oxygen delivery at the tissues level. A useful idea is, or field anchor rather, is a patient who is pale, cool, progressively altered while breathing appears adequate, right? That combination should prompt you to think circulation and perfusion problem and to treat and reassess aggressively, of course, within the EMT scope while, again, prioritizing quick packaging and transport. Now, again, as I've stated before, airway calls themselves are really a high yield for an exposure risk, and aerosol generating procedures or AGPs are the situations where airway management and respiratory support can really can aerolize the droplets and increase the chance of mucous membrane exposure, right? So CPR, nebulizer treatments, endotracheal intubation, CPAP are all listed here because they involve airway manipulation or pressurized airflow that can spread the aerosolized materials, which is why the chapter really emphasized using the appropriate PPE. At minimum, again, a mask and protective eyewear with just true eye shields during airway care, wherein aerolization is likely. Um, so a real world example, is when you're suctioning or ventilating a patient who is actively coughing or has fluid in the airway while a nebulizer or CPAP is being used. Those are moments where you want your PPE decisions made early rather than reacting just mid procedure. A common issue with new EMTs is treating PPE as just a nice to have once care is underway. The fix here is just to build it into your pre-contact routine, especially on breathing calls, so you can manage the airway effectively without just unnecessary exposure to yourself. Now, when breathing is adequate in adults, you're really looking for a consistent pattern, right? A rate between 12 and 20, a regular rhythm, equal rise and fall of the chest, clear and equal breath sounds on both sides, and enough depth to move meaningful tidal volume, right? The depth piece here is where a lot of real world assessment happens because the patient can hit the right number, so to speak, for like the respiratory rate, but still ventilate poorly if breaths are shallow. So pairing the rate with chest expansion and breath sounds keeps you kind of grounded in actual ventilation effectiveness. So if you think about a patient who is, speaking comfortably in full sentences with normal chest rise, clear bilateral sounds, that overall picture supports adequate ventilations, and your job becomes to continue monitoring and having the readiness to intervene if that pattern were to change. It's unfortunate though, a common issue is letting one normal sign, like a normal rate, override the rest of your exam, right? The correction is to treat adequate breathing as a bundle of findings that agree with each other, then trend them over time. So now that we have an idea of what adequate breathing is, let's look at inadequate or abnormal breathing, right? So abnormal breathing starts with a few kind of patterns, right? You can detect relatively quickly. For starters, a respiratory rate below 12, above 20, and again, we're talking about more of adult patients. An irregular breathing rhythm, breath sounds that are diminished, absent, noisy of some sort. Uh, Visibly reduced airflow at the mouth and nose, mechanically, a rate that is too slow or too fast can reduce the effective minute ventilation, either by not moving enough breaths or by turning breathing into, shallow, inefficient movements that doesn't deliver enough fresh air to the alveoli. So you always pair rate and depth and overall air movement. Okay. So if we look at a patient who is breathing rapidly, but you can barely see the chest expansion, and breath sounds are faint or noisy, that combination should really prompt immediate evaluation for inadequate ventilation and preparation to support breathing rather than waiting for the situation to just simply declare itself. So now, after you've noticed abnormal heart rate, or sorry, not heart rate, breathing rate, rhythm, breath sounds. The next set of clues comes from what the chest and skin are actually telling you. Unequal or inadequate chest expansion, shallow depth, both point towards reduced tidal volume. And that matters because the patient can look like they're breathing a lot while still failing to like move enough effective air for adequate ventilation. Increased effort, especially when you see the body working to inhale, really signals that the patient is trying to generate stronger pressure changes to move air. And it also warns you that fatigue may be close in the underlying problem, just if the underlying problem isn't corrected. Now, the skin findings help you interpret severity. Pallor and cool, clammy skin can reflect poor perfusion, while cyanosis is a later sign that oxygen delivery has fallen behind. Retractions is where skins is pulling in around the ribs or above the clavicles during inspiration. Those are other like high yield signs of increased work of breathing, showing that the patient is generating significant negative pressure to inhale. A practical field assessment of this one is that the patient who is like speaking in those short phrases with like visible retractions and minimal chest rise, that combination should push you to prepare for ventilatory support rather than again waiting for the trend to worsen. Um, Now, two breathing patterns on this screen are important because they can fool providers into thinking ventilation is actually adequate when it's really not. We have agonal gasp. Now, agonal gasps are occasional abnormal gasping breaths that can occur after the heart has stopped, right? They reflect the residual signaling to breathing muscles, but they are not frequent or effective enough to really oxygenate the patient, which is why the presence of a gasp should not delay the appropriate resuscitation steps. We have Cheyenne or Chain Stokes respirations. These are different. They follow it kind of like cyclical pattern where breathing will gradually increase in both rate and the depth, then decreases, followed by periods of apnea where just there's no breathing taking place. And the figure here is illustrating that waxing and waning pattern with pauses in the breathing. So a field evaluation or something that you can kind of an example, if you will, is arriving to a patient who has intermittent gasps with long pauses. If you treat those gasps as normal breathing, you lose time that should really be spent supporting ventilation and when indicated beginning chest compressions. A common pitfall here is equating any visible chest movement with adequate breathing, right? The correction is to assess the pattern and its effectiveness. If respirations are, infrequent, irregular with prolonged pauses, or clearly cyclical with apnea, treat it as inadequate ventilations and manage accordingly. We have a couple more. We have ataxic and Kussmaul respirations. These are also both abnormal respirations, but they point you in a different direction clinically, and they can have different implications for how quickly a patient may deteriorate. Ataxic respirations are irregular, ineffective, sometimes without a clear repeating pattern. And they can be seen after a serious head injury. So, when you see this pattern, you should be thinking about loss of normal respiratory control and the potential for ventilation to fail, even if the patient is still making some effort. Now, Kussmaul respirations, on the other hand, are kind of deep and rapid and are commonly associated with metabolic acidosis. This pattern is typically the body's attempt to correct an internal chemistry problem by changing ventilations. A helpful clinical anchor is comparing two patients, right? So we have one with erratic, ineffective breaths after a head injury versus another who is breathing deeply and rapidly with consistent pattern. Both need evaluation, but the first pattern should make you especially alert for sudden loss of ventilation effectiveness. A common issue is assuming that fast breathing again is always either panic or always adequate. This fix is to just identify the pattern, deep and regular versus irregular and ineffective, and then decide whether ventilation is actually adequate based on depth, chest rise, and just the overall patient status. Now, a key assessment point is that a patient can be moving air and still have compromised respirations, meaning that the overall exchange and delivery process isn't meeting the body's needs. Mental status is just one of the most practical indicators because the brain is so sensitive to inadequate oxygen delivery. A patient who becomes confused, unusually drowsy, or otherwise altered should always prompt you to consider inadequate oxygen reaching the brain, even if you're seeing adequate respiratory effort. Skin signs and conditions add another layer on top of that. Pallor often reflects poor perfusion. Cyanosis tends to appear again more as a later sign as oxygenation perfusion worsens. And then mottled or progressively abnormal skin findings tell you that the patient is not compensating well. An example is the patient whose breathing appears active but who is becoming less responsive, increasingly cyanotic. That combination should really move you away from their breathing so they're okay and towards reassessing airway patency, ventilation, and just overall perfusion. So, along with assessing ventilation and overall respiration indicators, you also consider oxygenation, right? Specifically, whether oxygen is being loaded onto the hemoglobin. And your pulse oximeter or oximetry is a routine vital sign that helps you estimate that part of the process. The chapter's emphasis is that the pulse oximeter provides a rapid, really non-invasive look at oxygen saturations, which is useful for trending a patient's response to interventions like airway positioning, O2 therapy, assisted ventilations. It's most valuable though when you treat it as a trend and interpret it alongside the patient's appearance. Okay. Um, End-tidal CO2. So end-tidal CO2 is the maximum concentration of carbon dioxide measured at the end of an exhaled breath. Okay, and it gives you a practical window into how well the patient is ventilating and how much CO2 is making it back to the lungs to be exhaled. A low end-tidal CO2 can happen when the patient is hyperventilating and blowing off CO2 faster than it's being produced. But it can also show up when less CO2 is returning to the lungs, either because of poor perfusion or because the cellular CO2 production is reduced when the body isn't effectively delivering O2 for normal metabolism. A high end tidal CO2 points you really towards ventilatory inadequacy, meaning that patient is retaining CO2 because ventilation isn't keeping up with the production, and an absence of CO2 is a strong clue that the patient isn't breathing at all. End-tidal CO2 is measured with either capnometry or capnography. Capnometry gives you a numeric reading, while capnography provides both a number and a waveform that really updates breath to breath, which helps you see changes in ventilation in real time. The normal end-tidal CO2 range is listed here is 35 to 45 millimeters mercury. And the best way to use that range in the field is as a reference point while you trend the patient's response to interventions rather than just treating one number as the final verdict. Another practical point is that end-tidal CO2 monitoring isn't limited to patients with advanced airways. It can be used in spontaneous breathing patients using a special like nasal cannula that samples exhaled gas, which can add meaningful information when you're trying to judge ventilation adequacy. So now let's actually get into opening the airway. So this is all about airway management, and airway management starts with that simple priority. If you can't open and maintain a patent airway, you can't ensure effective ventilations or oxygen delivery. So the first steps of emergency care focuses on airway and breathing assessment. So for an unconscious patient, the immediate job is to determine whether the airway is open and whether breathing is adequate. And correct positioning is a major part of making that assessment accurate. The supine position is generally the most effective for airway assessment because it gives you consistent access for airway opening maneuvers, observation of the chest, and preparation for ventilation if it's needed. If the patient is found in a position where supine is delayed, like entrapped or confined, you still address airway patency where you find them and then reposition as soon as you safely can. A clinical perspective is, you're arriving to a patient who's slumped sideways on a couch with snoring respirations. Positioning them supine and opening the airway often changes the effectiveness of ventilations just immediately, and it sets you up to suction and ventilate as needed. A common issue in new EMTs is skipping the positioning and going straight to oxygen delivery. The correction here is just to remember oxygen near the face doesn't help if air can't move through an open airway. So you need to position first, reassess, and then choose the next intervention. Now, when you need to reposition an unconscious patient, the guiding idea is to move them as a whole unit, keeping the head, the neck, the torso aligned as much as possible. But because you often can't rule out trauma too early, and any uncontrolled twisting can always worsen a potential spine injury. At the same time, airway management remains a priority. So the goal is controlled movement that gets you into a position where you can assess and manage the airway effectively. The most common airway obstruction in an unresponsive patient is actually the patient's tongue. Okay, so when the muscle tone relaxes, the tongue can actually fall back towards the really posterior pharynx and block airflow. And the figure illustrates that mechanism pretty clearly. A clinical anchor here is that an unresponsive patient with snoring respirations. That sound is a classic clue that the airway is partially obstructed by soft tissue. And just simple repositioning and airway opening can actually immediately improve air movement. A common issue here is moving the head and neck independently while rolling the patient. So delaying airway, or delaying airway opening because you're worried about a spine injury. The correction really is just to coordinate the move, maintain alignment, and just prioritize airway patency while using the appropriate airway opening technique, just based on your own suspicions of trauma or lack thereof. Now, the head tilt chin lift maneuver. So the head tilt chin lift is the pretty much the go-to airway opening maneuver for most patients when trauma is not suspected. Because it's a simple way just to relieve the most common obstructive in unresponsiveness, and that is going to be the posterior displacement of the tongue. The mechanism is pretty straightforward. Extending the head and lifting the chin moves the jaw and the tongue actually forward, opening the airway passage so air can simply move more freely into and out of the lungs. The figure here shows that the general positioning and hand placement concept. And it reinforced the practical goal you're watching for, and that's just improved air movement and just more effective chest rise once the airway is actually opened. Um, a comment, if we can kind of anchor this, if you have an unresponsive medical patient with, snoring respirations and just no signs suggesting trauma, using that head tilt chin lift to open the airway, then reassessing breathing and preparing suction or ventilation is just the most clean and repeatable sequence you can do. So here's the practical technique for the head tilt chin lift, and the goal again is simple: reposition the head and jaw so that the tongue and soft tissues move away from the back of the throat, and airflow improves. You're going to start with the patient supine, so you can see the chest rise. You can manage the airway. You can reassess breathing. Then place the heel of one hand on the forehead and apply firm backward pressure to tilt the head back. This extension is what really helps relieve the common soft tissue obstruction. Okay, with your other hand, you place your fingertips under the bony part of the lower jaw, kind of near the chin, and then lift the chin upward, bringing the entire lower jaw forward, rather than just tipping the chin rather. That jaw movement is really what helps open the airway passage. Now, when you suspect a cervical spine injury, the jaw thrust maneuver is really the airway opening technique that you kind of default to because it opens the airway while really minimizing head and neck movement. You're going to position yourself above the patient's head so you can really control the maneuver and coordinate with stabilization. Then place your fingers behind the angles of the lower jaw and lift the jaw upward and forward. Really, the airway goal is the same as the head tilt chin lift, just relieve that soft tissue obstruction. But the method really avoids that intentional neck extension. Your thumbs help position the lower jaw and keep the kind of mouth accessible, which kind of becomes important if you need to move quickly into suctioning or applying a mask for ventilation. Um, if you think about an unconscious patient or unresponsive patient found in like a fall or a motor vehicle accident, treat trauma as possible until it's ruled out. So you want to use a jaw thrust maneuver to open the airway, then reassess breathing, and then prepare for airway adjuncts or ventilatory support. So Even after you've opened the airway with the head tilt chin lift or the jaw thrust maneuver, you may find that the actual mouth is still closed, and you need to assess because of suctioning, airway adjunct placement, and just overall effective ventilation. It's often dependent on being able to visualize and clear that oral cavity. So you can use the cross finger technique, and it's a simple way to just open the mouth. You're going to place the tips of your index finger and thumb on the patient's teeth, then apply a pressure with your thumb on the lower teeth and then your index finger on the upper teeth. So the fingers kind of cross as they separate the jaw. The practical endpoint here is just a mouth opening wide enough to inspect for obstruction and to manage secretions without, forcing anything inside the mouth blindly. The figure here is meant to kind of lock in what a good jaw thrust looks like. This one's okay, but you're again positioned at the head. Your fingers are behind the angles of the jaw, and the jaw is displaced forward, so the mouth is slightly open, and the airway passage is more just likely to stay patent without moving the neck. The practical value is that the position can be held with your while you do the next steps of the airway management, checking for breathing, preparing suction, and then, of course, when indicated, applying some type of mask. Because again, maintaining the jaw forward helps reduce soft tissue obstruction while you actually work. To ventilate effectively, right, the airway has to be clear. So if blood, if vomitus or secretions are just sitting in the mouth or the pharynx, forcing air past the material risks pushing it deeper and increasing aspiration. So suctioning becomes a priority step in airway management. That's why suctioning equipment is considered essential for resuscitation, and you'll commonly encounter three forms: fixed suction mounted in the ambulance, portable powered suction you bring to the patient, and a hand operated suction that can be valuable when the power or battery reliability is kind of a concern. Um, a field anchor here is that the patient with, audible gurgling respirations and fluid draining from the mouth, you open the airway, position for drainage as appropriate, and then suction to clear the path really before attempting ventilation. Because again, ventilating through a contaminated airway is rarely effective, and it's going to just increase complications. Now, once you've decided suctioning is needed, the next question is whether your setup is actually capable of clearing the airway effectively. And that comes down to a few kind of must-haves. You need a wide bore, thick walled, non-kinking tube. And that matters because of the thick secretions and vomitus won't move well through like narrow or collapsing tubes. And you don't want your suction performance to really depend on the perfect position. So now let's look at techniques of suctioning. So reliable suctioning kind of starts before patient contact, and the routine is fairly straightforward. You want to inspect the unit regularly, confirm it's assembled correctly, test it, then choose the right catheter. So assembly matters because small leaks, loose connections, reduce the suction strength and make thick secretions really a lot harder to clear. So a quick check of tubing, bottle connections, tip connection really prevents avoidable failures. The performance checks is objective. Confirm that unit can generate more than 300 millimeters of mercury of vacuum when tested, so you're not discovering a weak suction at the patient's head when the airway is already full of a fluid. From an EMT standpoint, catheter choice is the final piece of readiness. Rigid for the oropharynx when you need a larger bore and control, and flexible when rigid isn't really appropriate. Then position the suction so it's accessible at the head during airway management. A clinical kind of aspect is a patient with active vomiting or copious secretions. If suction isn't assembled and tested ahead of time, you'll lose time switching equipment while the airway just remains contaminated. Now, suctioning itself is helpful, but it has a safety kind of ceiling. And the time limits listed here are designed to reduce the risk of making oxygenation worse while you're trying to clear that airway. So you want to do no more than 15 seconds per pass for adults, 10 seconds for children, and 5 seconds for infants. The physiologic reason is just simple. During suction, you're interrupting normal airflow and potentially removing oxygen from the airway. So prolonged suctioning can actually contribute to hypoxia, especially in patients who are already have limited reserves. So a practical way to apply this is to think in short, purposeful passes. Clear what you can see, stop, allow breathing, or provide ventilations as needed, then reassess and repeat rather than staying in the airway for too long. Um, and it's important to remember that you want to suction in circular motions on the way out of the mouth, not on the way in. And again, making sure you only suction as far as you can see. So don't blindly stick that catheter as deep as possible. Now, sometimes suctioning itself by itself won't solve the actual problem, especially when you're dealing with solids, thick debris, or just any type of material that's repeatedly blocks the catheter. And the approach here is just to stop, reposition, and then just clear safely, right? First, remove the catheter so you're not fighting equipment while you change position. Then log roll the patient onto their side to allow gravity to assist the drainage and just have better access. Now, if trauma is possible, that roll should be controlled as a unit, but the goal again remains airway access and protection. Now, once you can see into the mouth, clear it carefully with, gloved finger, only when the material is actually visible and reachable. Again, blind finger sweeps are a common error because they can push objects deeper and just worsen the obstruction. So a patient might have what was called frothy secretions, and frothy secretions can be kind of frustrating because they may reappear as quickly as you clear them. So really the practical strategy is to alternate airway clearance with ventilation support rather than just trying to suction continuously, right? So again, use a timed suction pass up to 15 seconds in adults and shorter in the infants and children, then switch to ventilations for about 2 minutes to help support oxygenation and ventilation. And just keep repeating that cycle until you've kind of gained control of the airway, just as much as possible. The physiology behind this approach is that the patient still needs ongoing ventilation and oxygen delivery. So prolonged suctioning interrupts that airflow. So alternating helps you clear the airway while also meeting the just body's basic needs. Um, Airway adjuncts. So good. Yeah, basic life support airway adjuncts, BLS airway adjuncts. So these exist for one main reason, and that's just to help you maintain a patent upper airway when the patient can't, especially when the tongue relaxes and becomes the most common obstruction in an unresponsive patient. So the overall goal is to really keep a clear path for air and oxygen to move toward the lungs, and the oropharyngeal airway is one option that physically helps keep the tongue from collapsing backwards and also improves access to suctioning the oropharynx when secretions are present. So, an idea here, a practical idea is that, if you have an unresponsive medical patient, with noisy, obstructed respirations and just pooling secretions, once you've opened that airway and cleared what you can, an adjunct can help you maintain the patency while you reassess and prepare ventilation. So again, you utilize that head tilt chin lift jaw thrust to open the airway. You drop that BLS airway adjunct to maintain the airway. Now, from an oropharyngeal airway, an OPA, the decision hinges on one key assessment finding, whether the patient has what's called an intact gag reflex. So, indications include unresponsive patients without a gag reflex, whether they're breathing or apneic. And any apneic patient you're ventilating with a bag mask device, because maintaining patency becomes essential to effective ventilations, you need to have that OPA in place. Contraindications, or reasons why you would not insert the OPA, again, are just as important as indications. A conscious patient and anyone with an intact gag reflex, because that gag reflex is a protective airway mechanism. And inserting that OPA into a patient who can still gag can trigger vomiting or even some type of spasmodic closure at the vocal cords, which again, increasing aspiration risk and just making ventilation a lot harder. Now, a nasopharyngeal airway is typically better tolerated adjunct when a patient is unresponsive or has an altered level of consciousness, but still has an intact gag reflex, and they are unable to maintain an airway on their own. Now, the practical reasoning is that airway compromise in these patients is usually a combination of reduced control of the upper airway and accumulating secretions. And you need a way to really support the patency without provoking the gagging and vomiting the way an OPA might. So indications for an NPA include semi-conscious or unconscious patients, but again, who have that gag reflex, okay? Especially when they're not tolerating that OPA. So it's the common solution when airway support is needed, but gagging makes OPA unsafe. The major caution point, though, is trauma. A severe head injury with blood draining from the nose and a history of a fractured nasal bone are listed as contraindications because those findings just kind of raise concern for significant nasal or skull base injury and kind of make just insertion risky. The biggest issue is that if there is a crack in that basilar skull behind the kind of the nose, if you insert that OPA, there's a chance that you might insert it and it might kind of poke the brain, so to speak. So that is kind of why that contraindication is there. Now the recovery position, right? So you might find a patient in the left lateral recumbent position or right lateral recumbent position, but when you put them in this position, we call it the recovery position. So this is a real simple but really valuable airway strategy for a patient, but more specifically for the right patient, okay? And that's going to be an unconscious patient who is not injured, is able to breathe on their own, and has an adequate rate and depth. That means they don't need any assisted ventilations. Rolling that patient onto their side helps maintain a clear airway by really allowing secretions or vomitus to drain rather than pooling in the like posterior pharynx, which really reduces aspiration risk and makes an ongoing airway maintenance easier and during monitoring at least. Supplemental oxygen. So, supplemental oxygen is really indicated when a patient is hypoxic, right? So, that means that tissues and cells aren't getting enough oxygen to meet the metabolic needs. And the point is to restore oxygen delivery before the patient decompensates. Because certain organs are especially sensitive to reduce oxygen delivery. So changes in mental status, worsening skin signs, or just increased work of breathing should really push you to treat earlier rather than waiting for those late findings like cyanosis. So the decision rule is kind of simple. You don't want to withhold oxygen from a patient who might benefit from it. Even if you're aware of special situations that we discussed earlier in the chapter, the priority is correcting the hypoxemia because the immediate risk is oxygen deprivation, not long-term complications. Now, in a pre-hospital setting, you're going to deliver oxygen using equipment that stores oxygen either as compressed gas in cylinders or in some settings as liquid oxygen. Compressed gas cylinders are most common EMS source because they're portable, they're durable, they're really easy to pair with regulators and delivery devices. So, which kind of fits the pace and movement in the field. Now, liquid oxygen systems are an alternative you may encounter, especially in a home setting for patients who require continuous oxygen, because they can store really large volumes. But they also come with handling requirements that kind of differ from standard portable cylinders. Um, Now, when we're talking about oxygen, just cylinders and supplemental oxygen, it's important to understand that transporting a patient who is already using oxygen at home, you need to recognize the source type. And it's going to help you anticipate what equipment interfaces you'll see and what safety considerations apply when transferring or just continuing oxygen therapy. A common issue is just assuming all oxygen sources kind of behave the same. To correct that line of thinking, you need to be able to identify the supply type early so you can actually handle and connect equipment appropriately and just avoid the overall delays that could have been prevented. Now, cylinder safety is all about respecting pressure. Okay, these containers hold compressed gas, and if the valve or the neck of the assembly is damaged, the cylinder can actually become a high energy projectile like a missile. So, handling and securing are part of the actual patient care. It's really not an afterthought because before transport, you need to ensure that the correct pressure regulator is firmly attached and that the cylinder is secured with proper mounting brackets when it's stored. The same principles apply when a cylinder is in use during transport. Position and secure it so it can't fall, won't strike equipment, or or shear the valve in a sudden stop or collision. A field anchor here is moving from scene to ambulance with limited hands, right? It's tempting to set a cylinder down just for a second, but any unsecured cylinder will tip easily and can injure the crew or the patient. So the safer workflow is just secure first and then move. Now, the pin indexing system is a vital part of your O2 regulator. So it's a system and it's built-in compatibility check for those portable cylinders. The regulators have pins that match these specific hole patterns on the cylinder valve face. Okay, and the patterns differ by gas type. So the wrong regulator physically will not fit onto the wrong cylinder. Now, in practice, that means it's not just best practice, it's double checking your equipment, right? It's double checking to make sure that the equipment you have is designed to prevent mismatches like connecting an oxygen regulator to a carbon dioxide cylinder, right? A clinical anchor is preparing oxygen in a crowded scene or a low light. The pin indexing really system will reduce the chance of a critical connection error when you're moving quickly. But it still depends on you aligning the regulator correctly and ensuring the fit is secure. Now, a pressure regulator exists because the cylinder pressure is just way too high for direct patient use. The regulator reduces the pressure down to more of a practical, consumable working range, typically between 40 and 70 psi, so oxygen can be delivered safely and just consistently. From there, the system usually routes oxygen in one or two ways through a quick connect fitting that can feed a pressure hose or ventilator or resuscitator interface, or through a flow meter that allows controlled oxygen delivery measured in liters per minute for your common oxygen devices. Now, flow meters are commonly what you're going to see in the pre-hospital setting, and it's part of the oxygen system that really let you control and deliver a measured flow rate. And in EMS, they're typically attached to the pressure regulator so that you can go from cylinder to patient device quickly. Two types show up commonly in training: a pressure compensated flow meter, which uses a float ball in a calibrated tube and is affected by gravity. So it needs to be upright to read accurately. And then you had a Bourdon gauge style, which really relies on a gauge mechanism and can be used in different positions without the same gravity limitations. Now, the practical EMT implication here is that the equipment design influences accuracy. So if a float ball system is tilted or laid flat during transport, the reading can be misleading and you may not be delivering the actual flow that you think you are. Now, supplemental oxygen, again, it's a core EMT intervention, but it does come with two hazard kind of categories that shape how to use it. You have a combustion risk in the environment and an oxygen toxicity as a physiologic concern when oxygen levels are excessive for longer than needed. Now, a combustion risk matters because oxygen-rich environments make fires burn faster and hotter. So your oxygen setup has to include an ignition source awareness and safe cylinder handling. Now, oxygen toxicity matters because the chapter really notes that not every patient benefits from high concentration of oxygen. And in select populations, excessive oxygen can actually be harmful. So when the pulse oximetry is available, oxygen should be tailored to the need of the patient rather than applied at maximum by default. Now, oxygen itself, it doesn't burn or explode, but it does support combustion, right? So, meaning it can make a small ignition source become a serious fire in an oxygen-enriched space. So the practical use is to control ignition risk. Anytime oxygen is flowing, keep cigarettes, open flames, and spark-producing activities away from the patient and the oxygen source, and be especially cautious in enclosed areas where oxygen can accumulate. Adequate ventilation matters because it reduces the chance of creating an oxygen enriched pocket of air, which is particularly relevant in confined rooms, and in the back of the ambulance or just around equipment that may generate a spark. Cylinder handling ties kind of directly into safety as well. Again, never leave a cylinder standing unattended because it can fall, damage the valve assembly, and then create both an injury hazard and a fire supporting oxygen leak, if you will. So to re-emphasize, oxygen toxicity refers to cellular damage that can occur when oxygen levels are excessive for longer than necessary. And the chapter's kind of practical takeaway is that high concentration of oxygen are not automatically the best choice for every patient who just simply looks sick. Now, while hypoxemia is immediately dangerous and should be treated, oxygen dosing can be matched to the need when you have a pulse oximeter. Administer the minimum amount of required to maintain an oxygen sat at or above 94%. Okay, rather than just applying maximum flow O2 by default in every situation. The text also cautions that certain illnesses, including COPD, are part of a group where excessive O2 over time may have detrimental effects. But the key EMT implication is balance. You don't withhold oxygen from a patient who needs it. You treat hypoxemia first and then titrate based on the patient's response and measurable saturations when available. So in the field, oxygen delivery and ventilation support usually come down to three kind of tools. You have the non-rebreather mask, the bag mask device, and the nasal cannula. Okay. And the way you choose among them is driven by whether the patient is ventilating adequately. Okay. So when the patient is breathing adequately but needs higher oxygen concentration, a non-rebreather mask is typically the go-to option. While the nasal cannula is often used when hypoxemia is kind of on the milder side or when the patient won't tolerate a mask. Now, when ventilation is inadequate, slow, shallow, fatigued, or absent, the bag mask device becomes the central tool because oxygen near the face won't simply solve a problem the patient can't ventilate on their own. So your priority shifts from moving air effectively while maintaining airway patency. So a non-rebreathing mask, a rebreather mask, if you will, is typically again the go-to option when a patient is breathing on their own but needs a higher concentration of oxygen, more so than a cannula can actually deliver. The reason it works is mechanical. It's a mask plus reservoir bag system, so the O2 collects in the reservoir bag and the patient draws from the supply during inhalation while the flapper valve ports on the sides allow exhaled gas to exit instead of being rebreathed. So you're reducing the amount of CO2 rebreathing and increasing the fraction of inspired oxygen when the seal and flow are set correctly. Now, clinically, it fits the patient who is clearly hypoxemic but still ventilating adequately, moving air with a reasonable depth and rate. So your immediate aim is to raise O2 delivery without taking over ventilation. Now, for a non-rebreather mask to do its job, again, the reservoir bag has to be ready before it even touches the patient's face. So you actually need to pre-inflate the bag first and then place the mask so that the patient is drawing oxygen from the reservoir right away rather than pulling in room air while the bag fills. So once it's on, you want to adjust the flow so the reservoir bag does not fully collapse during inhalation. The practical target is that the bag should stay at least partially inflated, and if it's collapsing completely, you increase the flow until it maintains volume with the patient's breathing. This becomes especially important in infants and children because the reservoir size is much smaller and their breathing patterns are just a little different. So you got to watch the bag closely and match the flow to keep it inflated. One of the easiest mistakes to make is leaving the mask on the patient's face after the oxygen is turned off. So without the flow, the setup can actually trap exhaled gas and the patient can rebreathe carbon dioxide. So discontinuation means the mask comes off the patient. Now it's important to note that the non-rebreather mask, the typical flow rate is going to be between 10 to 15 liters per minute, and it can deliver up to 90% oxygen concentration. Now, a nasal cannula delivers oxygen through two small little prongs in the nostrils, and it's really designed for situations where the patient is ventilating adequately and needs a modest increase in inspired oxygen. The flow range is typically 1 to 6 liters per minute, which corresponds roughly to about 24% to 44% inspired oxygen. And a practical point from this chapter is comfort, right? Higher flows through a cannula are generally not recommended because dry oxygen can irritate the nasal mucosa over time. Clinically, the cannula fits the patient with mild hypoxemia or the patient who won't tolerate a mask while still allowing you to communicate, reassess, and escalate if the patient's condition worsens. Now we're talking a lot about oxygen concentrations, like how much you're actually giving the patient. It's really important to note that the air that you're actually breathing only has about 21% oxygen. So the non-rebreather mask and nasal cannula, we're giving them more than what they would normally breathe in just from the environment. And that's largely dependent on the flow rate and then also the seal on the patient's face. So here for the nasal cannula, 1 to 6 liters per minute will attribute to 24 to 44% of oxygen concentration. Being on the lower end of liters per minute, you're closer to the 24, which is still pretty close to the atmospheric oxygen, but still just a little bit more. Now, cannulas, again, are best reserved for that mild hypoxemia, okay, or situations where, again, the mask is not tolerated because a lot of people get like claustrophobic. But they do have a real limitation that you need to recognize relatively quickly. If the patient primarily breathes through the mouth or has significant nasal obstruction, a cannula may provide little benefit because the O2 delivery is bypassing the patient's main airflow route, which is going to be the mouth. So for longer use, dry oxygen can really, like I said, irritate that nasal mucosa. So you can actually make it humidified, right? So humidification can be considered when transport time is extended. But again, the chapter here also points out that there's a practical trade-off. Humidification can increase aerolization of droplets, which an infection control concern during contagious respiratory illness situations. Um, but yeah, we'll cover in labs typically how to actually make it humidified. We also have something called partial rebreathing mask. It looks a lot like a non-rebreather because it uses a mask, um, but it doesn't use a reservoir bag. But again, the key functionality here, and another thing, there's no one-way valves on the side, which means the patient will rebreathe a small portion of exhaled air. In this chapter, that rebreathing can be useful when you want to increase the patient's carbon dioxide levels, making it the intended mask choice for situations like, suspected hyperventilation syndrome, where that excessive CO2 elimination is part of the problem. But it still depends on the patient's breathing adequately on their own. So it's not a substitute for ventilatory support, and it isn't the default device for any significant hypoxemia when you're trying to maximize oxygen delivery. Sometimes you're going to arrive to find a patient already on an oxygen device that you don't use every day. And the Venturi mask is kind of a classic example. Its whole purpose is controlled oxygen delivery, not as much oxygen as possible. So the key idea is that the device has pretty much selectable settings that let you vary the percentage of oxygen delivery while maintaining a consistent flow, which matters when someone is physiologically stable but needs a more precise oxygen mix than a simple nasal cannula can provide. Clinically, think of it inter facility or nursing home pickup where the patient is calm, breathing on their own, and the facility has them on a Venturi mask for controlled support. So you should recognize what it is, confirm it's actually connected and functioning, and then decide whether it still matches what the patient needs based on your assessment. Now, oxygen only helps if it's delivered, like I said, to the airway that the patient actually uses. And with a tracheostomy, that airway is the stoma inside the neck, not the mouth and not the nose. That's why a nasal cannula on the face or even a non-breathing mask over the mouth may do essentially nothing for oxygen delivery in a trach patient because their ventilation bypasses the upper airway entirely. So the figure here shows where captures the kind of the practical workaround. If a tracheostomy mask isn't available, you can use a standard face mask positioned over the tracheostomy opening, so oxygen is directed where airflow enters into the lower airway. Um, Kind of a realistic field example is arriving to a care facility where the patient is getting more short of breath and someone reflexively placed an oxygen on the face. So your correction obviously is to expose the neck stoma, deliver oxygen at the stoma, and reassess breathing effectiveness rather than chasing numbers or changing devices at the face. A tracheostomy mask is kind of built for just one job. It's really covering the tracheostomy opening and securing oxygen delivery at the point of the stoma with a strap system that kind of keeps it positioned at the neck. The problem is that these masks are commonly found in like higher acuity settings like intensive care areas, and they might not just be sitting in your standard EMS gear. So you have to be ready to really adapt without losing time. The practical improvisation, if you will, is kind of straightforward. You just place a standard face mask at the tracheostomy opening and adjust the straps kind of at your hand position to get the best fit you can. And it's important to remember that, even though the mask is, shaped for a face, it can often seal well enough over the neck to make the oxygen delivery meaningful when it's, positioned, correctly. Now, at the EMT level, most airway calls are managed successfully by just doing the basics just exceptionally well. And that's not like a consolation prize. It's often the most effective care you can provide early. So when basic airway maneuvers, suctioning, and bag mask support are done correctly, ventilation and oxygen delivery can improve quickly enough to stabilize the whole situation while you continue your assessment and transport planning, which is exactly why this course stresses the mastery at the EMT level instead of treating advanced airways as like the real fix. So, imagine like an unresponsive patient with like noisy, wet respirations, poor chest rise. Opening the airway, clearing secretions, and providing controlled ventilatory support can be the difference between effective and ineffective care even before any ALS interventions enter the picture. Now, at the same time, airway management is a high exposure task. So, suctioning and any airway manipulation can aerolize the fluids. So, again, standard precautions aren't optional later, they're part of the setup, including a mask and protective eyewear, with escalation during high risk infections when it's indicated. Now, recognizing inadequate ventilation early is a practical EMT skill because the patient may still be breathing but not moving enough air to meet that metabolic need. We've talked about this. So altered mental status is one of the most important red flags here. So when the brain isn't getting adequate oxygen delivery or the patient is, retaining carbon dioxide, you can see confusion, you can see decreasing responsiveness or just an inability to participate. That's kind of your cue to reassess breathing, um, reassess their effectiveness of the breathing, rather than assuming the airway is fine. Inadequate minute volume is the concept that really ties it together. Ventilation depends on both the rate and the depth, so a patient can sit at a normal respiratory rate and still fail because breaths are shallow and the tidal volume is reduced, which can drop the effective alveolar ventilation and lead to worsening hypoxia over time. Now, accessory muscle use and visible fatigue also matter because they signal an increased work of breathing. Patients can compensate for only so long before they get tired. And once fatigue sets in, their ventilation can deteriorate rapidly. Now, a simple field anchor is the patient who is breathing 18 times a minute but is drowsy, speaking in fragments, and just pulling with the neck and chest muscles. If you focus only on the rate, you're going to miss the bigger problem. Instead, again, treat patients' ventilations by supporting it and reassessing the response. Now, assisted ventilations is what you do when a patient is still breathing but clearly isn't moving enough effective air. And your goal is to support ventilations without turning it into kind of a fight. Start by explaining what you're about to do because coaching lowers anxiety, helps the patient accept the mask, and then place the mask over the nose and mouth with a deliberate focus to seal focus on the seal, and then airway position so your breaths actually reach the lungs. You want to squeeze that bag each time the patient inhales so you're augmenting their own effort rather than forcing breaths against them. And after about the first 5 to 10 assisted breaths, adjust what you're delivering so the tidal volume is appropriate. Use visible chest rise as kind of your practical indicator rather than bigger is better, right? The deeper physiology point is that ventilation depends on both a rate and depth. Okay, so your job is to help the patient achieve an adequate minute volume while avoiding the common complications of overly forceful or overly rapid bagging. Okay, so if you picture a fatigued like COPD patient who's breathing but barely moving the chest, synchronized assistance and like careful depth can improve ventilation and reduce work of breathing while you continuously reassess their mental status, their chest rise, and their overall response. Now, artificial ventilation begins the moment you determine the patient is not breathing, and the key operational message here is to start immediately rather than waiting for better conditions or for more equipment. The two methods listed are mouth to mask and a one or two person bag mask device. And your choice really depends on what you have in hand and what you can do effectively while maintaining airway patency and managing the patient's secretions. Mouth to mask is the practical backup when a bag mask device isn't available or isn't ready, while a bag mask ventilation becomes the standard field approach when you need to provide consistent ventilatory support. Especially when you can use a two-person technique to maintain a seal and deliver effective chest rise. A clinical anchor is really the apneic patient with a pulse after a suspected overdose. Open the airway, clear secretions as indicated, and then begin ventilations right away with the most effective method available. Then reassess chest rise and the overall response. It's important to note if the patient is not breathing at all, you want to provide rescue breathing. That's going to be one breath every 6 seconds for your adult patient. If the patient is breathing on their own, but at a good rate, but maybe their depth isn't quite right, then you would try to match their breath, whatever rate it might be. Now, to reiterate, the normal breathing is just driven by the diaphragm and just overall chest mechanics. The diaphragm contracts, the thoracic cavity enlarges, intrathoracic pressure drops, and again, air is drawn into the lungs. Again, negative pressure ventilation. Positive pressure ventilation flips that model by really forcing air into the chest from the outside using a device, which is why technique matters so much more than most people would expect at first. The physiologic depth move to keep in mind is that negative pressure breathing also supports venous blood return to the heart, while positive pressure raises intrathoracic pressure during the breaths, which can actually influence circulation if the rate or the volume is excessive. A clinical kind of idea here is that reassessing a patient who becomes more hypotensive after ventilation begins, the pattern should prompt you to kind of evaluate whether the ventilation approach is increasing intrathoracic pressure too much rather than assuming the patient is just getting worse. Now, these how the positive pressure ventilation works. It comes with it does work, but it comes with a trade-off that can largely be controlled with technique. Again, when that intrathoracic pressure rises during the BVM breaths, venous return to the heart can be reduced, which can lower the amount of blood that the heart pumps. So ventilations that are too fast, too forceful, can actually worsen hypotension rather than help the patient. It also takes more delivered volume to achieve the same effect as normal breathing because you're pushing air in really rather than drawing it in, which is why the practical target remains just enough volume for visible chest rise, not a full bag squeeze. Okay. The other common complications is gastric distension. So when the airway pressure is so excessive or the airway position is like not optimal, air can actually enter the stomach, distend it, and then set up vomiting and aspiration while also making ventilation harder by pushing up on the diaphragm. Okay. Now, when ventilation must be provided without a bag mask device, mouth to mouth and mouth to mask techniques do exist. But again, infection control and effectiveness really drive how they're used. Mouth to mouth ventilations are routinely done with a barrier device to reduce exposure to bodily fluids. And the chapter really emphasizes that barrier devices offer really just limited protection against airborne and airless pathogens. So in practice, mouth to mouth is reserved for extreme situations where mouth to mask ventilations with like a pocket mask is generally a safer approach when you're in a setting where a bag mask device just isn't readily available. And if the mask has an oxygen inlet and oxygen is available, you can deliver supplemental oxygen through the mask while maintaining a seal and just watching for visible chest rise. So now the bag mask device is really the most common way ventilations are provided in the field, but it behaves kind of differently than mouth to mask. It can deliver a higher oxygen concentration when it's attached to supplemental oxygen and a reservoir. Okay. Yet the amount of tidal volume actually delivered depends heavily on your seal and technique. So it may provide less tidal volume than mouth to mask ventilation unless you're consistently achieving chest rise with effective mask to face seal. With overall good technique, an experienced EMT can still deliver adequate tidal volume by focusing on airway position and a firm seal and squeezing only enough to produce visible chest rise rather than just trying to empty the entire bag. The figure really reinforces the key performance requirements. With an oxygen reservoir, a solid seal, a BVM can deliver very high concentrations, but without the seal, that advantage drops, right? So one major complication to anticipate is that gastric distension we talked about, and that's just air inflating the stomach during artificial ventilations, which is most likely when ventilations are delivered too forcefully or too rapidly. And it can also occur when the airway is obstructed or poorly positioned, so the air actually takes the path of least resistance into the stomach instead of the actual lungs. Now, this BVM can be utilized without supplemental oxygen. It can just be used just like a pump would be, and it can deliver 21% oxygen, right? And that's because it's simply taking air from the environment and pushing it into the patient. Now, if it is hooked up to supplemental oxygen, typically at 15 liters per minute, with a proper seal and proper technique, it can deliver up to 100% oxygen. So definitely one of the more higher, if well, the highest concentration possible. Now, preventing gastric distension really comes down to just controlling where the air goes and how much pressure you're generating, right? And the first lever is just airway position. If the head and jaw position allows airflow to reach the lungs easily, less air is forced into the stomach. The second lever is just rate. When ventilations are too rapid, airway pressures rise and exhalation time is reduced, which increases the likelihood of air entering into the stomach. And it just makes ventilation less effective overall. Now, the third aspect is volume. Deliver only the amount needed to create visible chest rise because, again, excess volume increases pressure without improving ventilation goals and increases gastric inflation risk. So if the abdomen begins to look distended, the immediate response is to stop escalating force, recheck airway position and mask seal, and continue to rescue breathing with controlled rate and volume while keeping suction ready in case vomiting does occur. So this approach really keeps the focus on effective lung ventilations while minimizing the predictable complications that come from just overbagging the patient. Now during chest compressions, okay, the chest wall movement can actually generate a basic pump effect for air movement, okay? So compressions actually tend to force air out, and recoil creates a negative pressure that allows air to move to the back end, right? So producing a passive ventilation. This matters most in patients receiving chest compressions because it adds some airflow movement even when the patient is not breathing spontaneously. And it really complements your overall resuscitation efforts by just supporting oxygen movement in the airway space. This passive ventilation can be enhanced when the upper airway is kept patent with an OPA and when supplemental oxygen is actually applied. Because both steps reduce obstruction and increase the oxygen available in the air as being drawn in during recoil. So the practical takeaway is that airway patency still matters during compressions, and simple airway support plus oxygen can improve the effectiveness of the passive air exchange while you continue your coordinated resuscitation efforts. So a automatic transport ventilator or resuscitator, that is a ventilation device that's paired with like a control box that allows just key ventilation variables to be set, which can standardize delivery and free a provider's hands for other patient care tasks. The trade-off is that it does not have the same kind of sophistication as a hospital ventilator, so you don't treat it as like a simple set it and forget it kind of thing. It requires continuous reassessment of chest rise, airway patency, oxygenation trends when available, and just overall patient response. So the value is practical workflow. It can reduce the workload of manual bagging and allow the team to focus on maintaining a mask seal, managing the airway, preparing transport, and monitoring changes. Especially in compliance or resistance that just suggests the patient's condition is changing. But even with when a device is used, the priority still remains the same as with the manual ventilation. Deliver effective ventilations without excessive pressure, keep the airway clear, and be ready with a backup plan if the device isn't achieving adequate chest rise or if the patient deteriorates. So now let's move on to CPAP, continuous positive airway pressure. Okay, so this is a non-invasive way to provide ventilatory support to a patient in respiratory stress while they're still breathing on their own. It's really become a common EMT level tool because it can really reduce the work of breathing and improve oxygenation without immediately moving to invasive airway steps, right? Many patients are already familiar with the concept because really CPAP is widely used at home for obstructive sleep apnea, which is what the figure here is showing. It's a mass-based positive pressure used to keep the airway supported during sleep. So in the EMS setting, the same basic concept applies to selected like, respiratory distress patients who can cooperate with the mask and continue breathing. And your focus is really on integrating CPAP into a structured respiratory assessment, right? airway patenance, ventilation effectiveness, oxygenation status, and trends over time, right? The next part of the sequence is just understanding what CPAP is actually doing inside the lungs. And it what it's actually doing, it just works by really maintaining positive pressure in the lungs throughout the entire breathing cycle, okay? And that pressure changes the mechanical and gas exchange environment, kind of in a few important ways. By increasing pressure, CPAP can actually open up the alveoli that have collapsed and help prevent further collapse, which really effectively increases the available surface area for gas exchange, it really makes ventilation more efficient for the patient. So, with more alveoli participating, oxygen transfer across the alveolar membrane improves because the exchange surface is better recruited and supported. In conditions where fluid is interfering with gas exchange, the positive pressure also helps shift interstitial fluid back towards the pulmonary circulation, which really supports oxygenation by reducing the fluid related interface at the level of the alveoli. Now, how does it actually, work? How does it work? So CPAP is delivered through a face mask that's secured with a strapping system, and the effectiveness really depends on achieving a stable seal with minimal leakage while the patient continues to breathe spontaneously. That makes patient coaching part of the actual skill, explaining that what they'll feel, helping them tolerate the mask, and ensuring the mask sits correctly so the pressure is actually transmitted to the airway rather than venting into the environment. Caution is required in patients with potentially low blood pressure because positive pressure in the chest can actually reduce the venous return to the heart and again lower cardiac output, especially in the patients who is already kind of borderline. So this is the same hemodynamic concept you saw earlier with positive pressure ventilations, now applied into a more continuous form. Now, it's not appropriate when the patient is in respiratory arrest because the therapy really depends on spontaneous breathing. So once breathing stops, the priority becomes immediate positive pressure ventilations with a bag mask device. It is also contraindication in patients with hypoventilation, where the patient's rate or tidal volume are inadequate. Adding CPAP does not replace the need for actively moving air and correct minute ventilation. Patients who cannot speak, are unresponsive, can't follow commands, are also poor candidates because they're unlikely to tolerate the mask safely and may not maintain airway protection, which increases aspiration risk. The inability to protect the airway is also a hard stop for CPAP because positive pressure combined with secretions or vomiting can rapidly become unsafe. And then last we have hypotension. Again, another contraindication because again, CPAP can reduce venous return and further lower the cardiac output in a patient who is already so pressure compromised. Some more contraindications that prevent CPAP from being used in situations where it can worsen the patient or simply cannot be applied effectively. Signs of a pneumothorax, signs of significant chest trauma, any type of additional pressure can already to an already compromised thorax increase the risk and worsen respiratory and circulatory mechanics. A tracheostomy changes the airway route, so a face mask CPAP interface does not match how the patient ventilates, again, making it ineffective for its intended delivery path. Uh, Active gastrointestinal bleeding, nausea, vomiting, again, makes any type of mask-based positive pressures unsafe because of the aspiration risk. It's going to rise when the patient cannot protect their airway reliably. Any type of facial trauma can prevent an adequate seal, may make the mask placement painful or impractical, and cardiogenic shock or other severe hemodynamic compromise just raises concerns because the positive pressure again reduces venous return. Also, the inability to sit upright and inability to tolerate the mask both predict poor effectiveness because CPAP again requires that cooperation, the positioning, and consistent seal. Now, CPAP itself works through resistance that creates back pressure, okay? And that back pressure is most useful during exhalation because it helps keep smaller airway structures, the bronchioles, the alveoli, supported rather than collapsing. So the continuous pressure changes the patient's work of breathing by improving pulmonary compliance and maintaining more consistent alveolar recruitment across the breaths, which is why the setup emphasizes controlled, sustained pressure rather than intermittent forced breaths. Okay. The application range listed is about 7 to 10 centimeters of water. It provides a practical, like therapeutic window for initiating CPAP support while you watch the patient's response, right? Especially oxygenation trends and just the overall work of breathing. Um, the operational priority remains seal and monitoring. Pressure only benefits the patient if the mask fit is stable and you reassess continuously from improvement or signs that the patient is not tolerating the therapy. Now, CPAP is often effective, but complications are predictable and require active monitoring rather than just passive observation, right? Some patients experience claustrophobia and resist the mask, which can increase anxiety and make consistent delivery impossible. So, again, patient coaching, continual reassessment is are part of just safe use, right? Pressure-related complications include, the possibility of a pneumothorax, the ability to lower blood pressure, again by reducing venous return, which again is why ongoing blood pressure checks are also very important to pay close attention to the perfusion indicator. The key safety decision is kind of listed if the patient shows signs of deterioration, declining mental status, worsening ventilation, inability to follow commands, worsening hemodynamics. Then CPAP is removed, and then you transition immediately to positive pressure ventilations with the BVM. Um, Now, switching gears to some special considerations. After a laryngectomy, the patient now breathes through a permanent tracheal stoma in the neck, right? So, meaning the airway is rerouted and ventilation occurs through that opening rather than the mouth and nose, right? The figure emphasizes a critical kind of practical point. The midline tracheostoma is the only opening that can be used to ventilate the patient. So, identifying it correctly is really the first step before you attempt any ventilation strategy. In the field, that means you prioritize keeping the stoma unobstructed and directing ventilation support to the correct route. Because again, standard facial approaches can be ineffective when the upper airway no longer connects to the trachea. Now, airway opening maneuvers like the head tilt chin lift and the jaw thrust maneuver, are designed to relieve upper airway obstructions, but they are not required when ventilation is delivered through the tracheal stoma because the airflow route bypasses the mouth, the tongue, and the upper pharynx. So when a tracheostomy tube is in place, ventilation is performed directly through the tube using a bag mask device focusing on the same fundamentals as any assisted ventilation. Maintaining a secure connection, delivering controlled breaths, and watching for visible chest rise to confirm effective tidal volume. Okay. Now, if effective chest rise is not achieved, the next steps involved include reassessment of patency and equipment interface. And the following slide, we're going to continue on with the stomas. So now, when a patient has this tracheostoma, but there's no tube in place, ventilation has to be delivered at the stoma because, again, that's the airway opening that's going to connect to the trachea. And again, it's the most reliable way to do it. That it's used. The way to do it is to use an infant or child mask with your bag mask device to create a seal over the stoma. Okay, the smaller mask size makes it easier to fit the neck opening and minimizes leakage, and your real-time confirmation of this effective ventilation is going to remain the same. Do you see visible chest rise and fall with each breath? If you're not getting chest rise and fall, secretions or partial obstruction at the stoma is probably a common reason. So again, suctioning the stoma is an immediate corrective step before escalating force or changing rates. If ventilation through the stoma still isn't effective, an alternative approach is ventilating through the mouth and nose while sealing the stoma to prevent air from escaping through the neck. Now, that converts the system back to a single route for airflow, so delivered breaths can actually reach the lungs more effectively. The key is to keep the airway route decision kind of deliberate, ventilate through the opening that connects to the lungs, manage secretions, and then reassess chest rise after each change. Let's go ahead and switch gears to airway obstruction. Now, having a complete airway obstruction is a true emergency because once airflow is blocked, ventilation stops, oxygen delivery falls immediately, and the patient has very little time before they decompensate. The reason the slide emphasizes treat immediately is that there's no meaningful workaround. Oxygen near the face and reassuring words do not matter if air cannot pass the obstruction. So the typical context clues help you recognize the problem quickly. In adults, it often happens during a meal, while children, it often happens during eating or when small objects are accessible during play or just crawling around. The scene context matters for assessment because it raises suspicion early and keeps your airway evaluation focused on obstruction rather than assuming the problem is just medical or anxiety. Now, in unconscious patients, the most common obstruction is not a foreign object. Again, it's the patient's own tongue. Because loss of muscle tone allows soft tissue to fall back and narrow or block the airway, which is why basic airway opening and positioning can produce an immediate improvement. The slide also calls out two important obstruction categories. That do not involve foreign bodies, swelling from infection or an acute allergic reaction, and trauma related tissue damage. Those matter because repeated choking style attempts to clear the object won't solve the swelling tissue disruption, and they can delay the airway management steps that actually are going to improve the ventilation. Opening the airways, suctioning secretions, supporting ventilation if it's inadequate, and then just prioritize that rapid transport. Okay. The clinical takeaway is to think in mechanisms, right? Soft tissue obstruction responds to positioning adjuncts, while swelling and trauma can worsen over time, and that's going to demand just continuous reassessment, airway protection, and rapid transport. Now, mild airway obstructions mean that the airway is just partially blocked. So air is still moving, but the patient shows respiratory distress, often with noisy breathing, wheezing, and coughing. The key assessment distinction is good air exchange, where the patient can cough forcefully and still move meaningful air. In that situation, the most effective action is often to allow the patient to continue coughing because coughing, again, is the body's best tool for clearing a partial obstruction, really without driving that object deeper. So your role really becomes close to monitoring and readiness to intervene if the situation worsens. You watch for those changes in the inability to speak, cough strength, and just the overall work of breathing. The management approach is intentionally conservative here because unnecessary interference can actually convert a partial problem into just a complete obstruction. Now, again, to continue on, the mild obstruction can become an emergency when the air exchange is poor because the patient's efforts are no longer moving enough air to maintain oxygenation. So, poor air exchange often really shows up as increased difficulty breathing, and the presence of stridor, really particularly on inspiration, signals significant upper airway narrowing where the airflow is severely limited. The cyanosis indicates oxygen delivery has fallen behind, and the patient is moving into a more dangerous phase of hypoxia, which is why instruction is to treat immediately rather than waiting to see if the patient gets it out. At this point, the classification mild is misleading in like practical terms. The airflow is poor enough that you move into active obstructive management and prepare for rapid deterioration. Now, moving to a severe airway obstruction, it's defined by the absence of effective air movement. Okay, patients cannot breathe, cannot talk, can't cough. So the priority is recognizing that pattern like quickly and then acting without delay. Clinically, this often presents as a sudden inability to speak during eating, visible panic, and really the universal distress signal shown here in the figure. The patient grasps their throat while struggling to move air, and as oxygen delivery fails, they may begin to turn cyanotic and become progressively weaker. Now, the underlying physiology is pretty straightforward. If no air enters the lungs, ventilation stops and hypoxia develops rapidly, right? So the situation can progress from distress to collapse within minutes. In practice, a fast confirmation such, hey, are you choking, paired with no air, no voice, no cough, pattern keeps you reassessment efficient and prevents any misclassification. Okay. The key distinction to maintain is that a patient who can still cough forcefully or speak is moving air and should be managed differently than a patient who is silent and unable to ventilate. Now, once severe obstruction is recognized, treatment for the conscious patient begins immediately because the patient's ventilations have effectively stopped, and the clinical trajectory is rapid deterioration to unconsciousness. So the slide sequence matters. If the obstruction is not relieved, the patient will become unconscious, and at that point, you reassess breathing and pulse rather than continuing to treat them as a standing choking patient. If the patient is unresponsive, not breathing, has no pulse, the appropriate action is to begin CPR, beginning with chest compressions, because the problem has progressed to a cardiac arrest physiology and time sensitive resuscitation priorities take over. This is also where discipline reassessment will prevent delays. Gasping or minimal ineffective efforts are not the same as effective breathing. So the clinical decision is driven by whether the patient is ventilating and perfusing, not by that occasional movement pattern. Now, a reliable way to approach obstruction is to identify whether you are dealing with relaxed soft tissue versus a true foreign body, because the intervention must match the mechanism. If the airway is blocked by the tongue in an unconscious patient, a head tilt chin lift can restore patency by moving the tongue away from the posterior pharynx and then again reestablishing airflow, which is fundamentally different from an object that's lodged in the airway. Now, when a large obstruction is present in the mouth, removal is performed by sweeping it forward and out with a gloved index finger only when it's visible and reachable. Because again, the goal is to reduce obstruction without pushing the material deeper. Now, for the conscious patient with a severe foreign body airway obstruction, The abdominal thrusts are emphasized as the most effective method because they use the air already in the lungs to generate expelled force and dislodge the object. Now, it's important to note the recent changes in the AHA that they also want to do now alternating back slaps and abdominal thrust 5 and 5 until the item is relieved or the patient goes unconscious. Now, this sequence keeps actions disciplined, open the airway when the soft tissue is the culprit, remove what you can see, and again use the back slaps and abdominal thrusts when the problem is a true foreign body in an unconscious patient. Moving on to, again, some more special considerations. Dental appliances. Okay, so dental appliances can become an airway obstruction themselves, or just complicate ventilation if they shift during airway management, right? So a quick oral check is clinically meaningful before you begin positive pressure breaths. Okay, crowns, bridges, dentures, pieces of braces are just some examples that can loosen with trauma, vomiting, decreased tone. And if appliance is loose, it should be manually removed before ventilation so it does not dislodge and obstruct the airway once you begin bag mask support, right? Well-fitting ventures are different though. Leaving stable dentures in place can actually improve a good mask to face seal by just maintaining facial structures, which can actually make the ventilation more effective, right? So the decision rule is therefore, a practical and assessment based. Keep appliances that are secure and improving seal, remove appliances that are loose or interfering, then reassess during movement and transport because, again, stability can always change. Now, serious facial bleeding, right? So this is a challenge primarily because it threatens the airway, right? The face has a rich blood supply, so injuries can easily produce heavy bleeding, rapid tissue swelling, and both can spill into or narrow that upper airway. So as blood and secretions accumulate, ventilations become less effective and aspiration risks are going to arise, which is why airway clearance and airway positioning got to stay central while external bleeding is being managed. The immediate priorities always align with the slide. Control external bleeding with direct pressure when it's possible, and use suction as necessary to keep the airway as clear as possible so ventilations do not force blood deeper into the airway. Management really is dynamic because swelling and bleeding can always worsen during care. So, again, a frequent reassessment of just the airway patency, chest rise and fall, breath sounds is all part about maintaining control. So, lastly, let's look at when an advanced airway is needed. So, a paramedic performs the skill, but an EMT contributes. Okay, it's often what makes the procedure efficient and safe. Maintaining basic airway control, ventilating effectively, preparing suction, and just organizing equipment so that the team can move through a structured sequence. Pre-oxygenation is emphasized because oxygen enters the bloodstream by diffusion and increasing the oxygen available in the alveoli before an intubation attempt. It really extends the patient's tolerance of the brief period when ventilation pauses. From a practical standpoint, this really means that maintaining effective bag mask ventilations with a good seal and appropriate rate and volume rather than just rushing or hyperventilating. Equipment setup is part of the airway protection. Suctioning should be ready at the head. Adjuncts and backup airways should be accessible, and the team should be coordinated so airway patency and ventilations don't lapse during the transition. The Be Magic framework really provides an organized flow. Bag mask pre-oxygenation first. Evaluate for anticipated difficulty. Manipulate and position the patient to optimize the attempt while maintaining appropriate stabilization when trauma is possible. Attempt to first pass intubation. Transition to a supraglottic airway if intubation is unsuccessful. And then confirm placement and correct problems just immediately, right? This keeps the focus where it kind of belongs at the EMT level, just supporting oxygenation and ventilation, anticipate problems, and then ensure the handoff and monitoring remain tight through the entire airway procedure sequence. Okay. So that, ladies and gentlemen, means we are done with chapter 11. So I hope you enjoyed, and I will see you next time.